cleft lip and cleft palate. So it is a congenital deformity. Let's see about some important points. So etiology initially thought that the condition of the cleft lip and palate was inherited as an autosomal recessive trait, but now it is considered to have a multifactorial inheritance pattern. It is very important. The cause for cleft lip and palate is multifactorial inheritance pattern. So cleft lip, how cleft lip is occurred? Because of failure of fusion of the maxillary process with the medial nasal process. It is very important. Maxillary process with the medial nasal process, failure of fusion produce cleft lip. And cleft palate occurs due to failure of fusion of the palatine shelves, and failure of the tongue to descend also prevent the fusion of the palatine shelves. So cleft palate occurs due to the failure of fusion of the palatine shelves. So these are the etiological features. So genetic of cleft lip and cleft palate. So majority of the cleft lip and palate patients are regarded as a non-syndromic when the cleft occurs without other associated anomalies. So the remaining syndromic cases have additional characteristic features that can be subdivided into categories like chromosomal abnormalities, recognizable Mendelian single gene syndrome, teratogenic effect, and various unknown syndromes. So the high familial aggregation rates and recurrence risk and elevated concordance rates in monozygous versus dizygous twins provide further evidence for a strong genetic component in cleft lip and palate. So the syndromes associated with cleft lip and palate, like chromosomal, example trisomy 13, trisomy 18, and velocardiofacial syndrome. So the golden hair syndrome, example, the golden hair syndrome is patient having a bilateral cleft lip, macrostomia, mandibular hyperplasia, strabismus, and coloboma, and ear deformity. And another example is van der Rohe syndrome, the patient having a congenital lip pitch. So while numerous non-genetic risk factors have been identified, such as the use of anti-epileptic drugs and maternal alcohol or cigarette use, much effort has been concentrated on identifying the genetic contribution. So this point is very important. The gene implicated in cleft lip and cleft palate are TBX22 and PVRL1, IRF6, P63 and MSX1. These are the genes that implicated in the cleft lip and palate. This is very important point. Treacher-Collins syndrome patients also have absence of zygomatic arch, micrognathism, and cleft palate and low set ears. So these are the syndromes associated with cleft lip and palate. So next, moving on to clinical features. Mildest form of cleft lip is the presence of a simple notching of the lip on one side. In unilateral cleft lip and palate, the alveolus shift away from the cleft, resulting in a major distortion. So the cleft side is smaller and the non-cleft side is larger. So the lip is distorted and the nose is flattened on the cleft side. When there is a presence of cleft, that cleft side is smaller and non-cleft side is larger, and the lip is distorted and the nose is flattened on the cleft side. These are the important clinical features in cleft lip and cleft palate. There is no muscle develops from the medial nasal process in cleft lip. In nose, the septum is straight and the columella is absent. It is a bilateral cleft lip. So in bilateral cleft, the premaxilla is separated from the rest of the maxilla and protrude from the midline extraorally. So in bilateral cleft, the premaxilla is separated from the rest of the maxilla and protrudes from the midline extraorally. These are the bilateral cleft. In bilateral cleft, the nasal septum is straight and the columella is absent on intraoral structures of the nasal cavity through the cleft. So the presence of cleft palate result in the failure of creating a negative pressure, leading to regurgitation of milk and fluids through the nasal cavity. So it's very important in cleft palate infants, the regurgitation of milk and fluids through the nasal cavity. That's why we give palatal obturators. So some of the following conditions occur with a significantly greater frequency than in the general population. Natal or neonatal teeth. So presence of natal or neonatal teeth and congenitally missing primary or permanent teeth. And presence of supernumerary teeth. Microdontia, macrodontia and peg laterals fused teeth are present. And hypoplastic teeth are present. These are the features. Next, moving on to the classification. The classification of oral and facial clefts. There is a lot of classification. The first one is Fogg and Anderson's classification. Here it is a embryologic classification. So first group 1 is cleft lip only, that is single, that is unilateral or median cleft, present on the unilateral or median cleft, and double side, that is bilateral cleft. And group 2 is cleft lip and cleft palate, single, unilateral cleft and double, that is bilateral cleft. And group 3 is cleft palate only, extend up to the incisive foramen. So the limitation here is the failure to differentiate cleft of hard and soft palate. So the second classification is Kernahan and Stokes classification. Here there is 5 conditions. The first one is an incomplete cleft of the secondary palate. Is very important. Incomplete cleft of the secondary palate and the complete cleft on the secondary palate. And the third one is incomplete cleft of the primary and second palate. And the fourth one is unilateral complete cleft of the primary and secondary palate. And the fifth type is bilateral complete cleft of the primary and secondary palate. So primary palate involving prolabium, premaxilla and anterior septum, and secondary palate involving incisive foramen to uvula. The third classification is Kernahan stripped away classification. Here the stripped away classification is first introduced in 1971. The first one is, the number 1 is right lip, number 2 is right alveolus, number 3 is right alveolar process to the incisive foramen. The round structure is incisive foramen. And the number 4 is left lip, and number 5 is left alveolus, number 6 is left alveolar process to the incisive foramen. And the palate, the number 7 is hard palate, number 8 also hard palate, and number 9 is soft palate. This is the easy and easily remembered classification. So number 1 and 4 are lip, number 2 and 5 are alveolus, number 3 and 6 are primary palate, number 7 and 8 are hard palate, number 9 is soft palate. The fourth classification is classification of Davies and Ritchie. Davies and Ritchie's classification introduced in 1922. Group 1, Group 2 and Group 3. Group 1 is pre-alveolar cleft, unilateral or bilateral. And Group 2 is post-alveolar cleft. Here the cleft involving hard and soft palate. Group 3 is cleft of both primary and secondary palate. Here the limitation is most of the condition belong to Group 3 because cleft of both primary and secondary palate. The next classification is View's classification. This classification introduced in 1931. The cleft lip, class 1, upper lower notching, upper lip or lower lip, notching of the vermilion border not extending into the lip. Class 2 is cleft extending into the lip but not including the floor of the mouth, floor of the nose. And class 3 is complete unilateral cleft. And group 4 is any complete bilateral cleft. So here the easy is group 1 is cleft of soft palate only, group 2 is cleft of hard and soft palate, group 3 is complete unilateral cleft, group 4 is complete bilateral cleft. So here the limitation is it ignores the cleft of only the lip and alveolus, and there is no record whether the cleft was submucosal or complete. This is the limitation of View's classification. So there are 4 classification in View's classification. Group 1 is soft palate and pre-surgical management. The first one is maintaining adequate nutrition for the infant, and second one is pre-surgical orthopedics, and third one is counseling. These are the pre-surgical management. So we have to give adequate nutrition for the infant. To prepare the neonate for surgical repair of the lip, rule of 10 is used to ascertain the fitness of the child. So what is rule of 10? 10 weeks old. So the infant would be 10 weeks old and the 10 gram of hemoglobin is present and weight is 10 pounds. These are the rule of 10. 10 weeks old, 10 gram of hemoglobin, weight is 10 pounds. So the feeding is a major physical problem. Fabrication of feeding plate to facilitate feeding is essential. So parents need a great deal of assistance and psychological support during this process. So here we have to give the feeding plate for feeding, and the mother should be encouraged to breastfeed whenever is possible. So bottle feeding is initially difficult because of inability to create adequate suction. So there are variations in nipple design such as long nipples which directs milk into the pharynx. So spoon feeding is suggested as an alternative method of feeding. So this method is consuming. Spoon feeding is alternative method, but it's time consuming. So throughout the feeding, the child should be in a semi-upright position to prevent choking. It's very important. The child is positioned in a semi-upright position. So proper feeding during the first 3 months help the infant to gain weight, because the rule of 10 is 10 pounds weight. Minimum weight is 10 pounds. So we have to increase the child weight so that the surgical closure lip can be carried out by the end of the 3 months. So these are the obturator, that is suction feeding plate, showing the cleft palate. Pre-surgical orthopedics, it is known that the growth potential of nasal septum. So if there is a muscle pull to one side because of an unilateral cleft, these two forces combine and pull the major segment to the non-cleft side. So if an opposing force to the muscle pull and the nasal septum can be applied, the distortion can be minimized. So we have to give the opposing force to muscle pull and nasal septum. So it can be applied, it gives distortion can be minimized. So it is the goal of the pre-surgical orthopedics. So at the same time, if a shearing force can be applied to the minor segment, the major and minor segments of the alveolus and lip can be pulled together, then the repairing of the cleft becomes easier for the oral and maxillofacial plastic surgeon. So this type of orthopedic force prevent the chances for lip dehiscence after the lip surgery. So we have to give this plate before the surgery. So Hoffman in 1686 described the use of the maxillary strap to reposition the maxilla. So the maxillary strap to reposition the maxilla is given by Hoffman in 1686. Incoming voice call from. So this active orthopedic force is now given by 3 pieces of tape joined together by 2 elastic bands. So the orthopedic force is now given by 3 pieces of tape joined together by 2 elastic band. So the central portion of the tape tends to cup the premaxilla in bilateral cleft cases, so the stabilizing the segment. So strapping should be applied immediately after the birth and continue until the time of surgery. So it is very important, the strapping is applied immediately after the birth and continue until the time of surgery. So this is the strap that applied on the child face. Before the surgery, we have to give that strap. it decreasing the width of the cleft and enriching the lip segment near each other. So next step is counseling. The counseling of the parent is extremely important. They should be informed about the prolonged treatment that would involve people with various specialties. So we have to give the counseling for patient. We have to prepare the parents psychologically. It is a very important point. And the surgical management of cleft lip. The surgical closure of the lip is carried out on approximately 3 months of age. So when will you give the surgery on cleft lip? Is approximately 3 months. So Tennyson and Millard flap is used. Both the techniques involve preparation of the flap which are rotated over the cleft and united. So in some situation after the lip repair, a device called Logan's bow is used to reduce the tension in the lip wound. So it remains in place for 5 days. So this surgical repair will significantly improve the infant's appearance and relieve the parental apprehensions and increases their confidence in the future course of treatment. So the first surgery is cleft lip at the age of 3 months of age. So after we done the surgery, we have to place a device called Logan's bow. It would reduce the tension in the lip wound. So here the technique used are Tennyson technique. The first one is Tennyson technique and the second one is Millard technique. These are the important technique for cleft lip surgery. So the surgical management of cleft lip. So the surgical closure of palate is carried out by 18 months of age. So cleft lip is 3 months and cleft palate is 18 months. So it is to facilitate normal speech pattern. So repair is carried out by elevating flaps from the lateral and posterior region of the cleft. Great care should be taken to avoid injury to the greater palatine vessels. So because there is a greater palatine vessels running on the palate, so we have to great care to avoid injury to the greater palatine vessels. The denuded areas of the palate are left to epithelize. So when the tissue available is insufficient in palate, we have to take the flap from the tongue. So the surgical repair of the cleft palate can improve hearing and speech and also reduces the frequency of middle ear infection in these children. So why we do cleft palate in the early age? Because it improves the hearing and speech and it reduces the frequency of middle ear infections. So it is very important. If the tissue is in palate is not available or not insufficient, then go for a tongue flap. Next, moving on to the important therapy, that is speech and language therapy, SLT, speech and language therapy. Around half of children with a cleft palate will need speech and language therapy. 1 in 10 children with or without cleft have speech and language and communication needs, that is SICN. A cleft palate can affect speech and communication abilities in different ways. So a speech and language therapist initial assessment at around 18 to 24 months, followed by a further assessment once the child is around 3 years old. So speech and language therapy is important in cleft palate patients. So initial assessment is 18 to 12 months, 24 months. We have to give that therapy. So this assessment look at how well the child understand words as well as how they sound when they speak. So speech therapy techniques for cleft palate are auditory feedback, articulation practice, nasalized plosives, pharyngeal plosives, pharyngeal fricatives, and palatal dorsal productions. These are the technique of speech therapy for cleft palate. Next, moving on to additional surgical procedure. The first one is closure of the fistula. When a closed flap gives away, a fistula result. So the second one is surgical revision of the nose. Distortion of nose we give rhinoplasty, and the surgical revision of the lip. Scar on the labial surface can be made more invisible. And the fourth one is orthognathic surgery. Any problem with position of the jaw, we have to done orthognathic surgery and bone grafting to fill the defect near the tooth in the line of cleft. Then only we have to give the some prosthesis or implant on the patient. So we have to give bone grafting. So closure of the fistula, surgical revision of the nose, surgical revision of the lip, orthognathic surgery and bone grafting. These are the additional surgical procedure in cleft lip and cleft palate patients. It's very important, this flow chart, that is approach to the cleft patient, that is prenatal consult and genetic diagnosis is made, and at the birth, after birth at 3 months, lip tapping, that is NAM is given, and 3 to 4 months lip adhesion and lip repair surgery is placed, and 1 year palatal repair, and 2.5 years and 5 years speech therapy and VPI surgery, and 6 to 9 years orthodontic treatment, alveolar bone grafting is done, and 16 to 18 years orthognathic surgery is need to be done. So these are the flow chart for cleft patient. We have to remember. So main is cleft lip surgery is done at 3 months and cleft palate surgery is done at 18 months.